As I said, I was self-medicating. I was drinking much too much alcohol. I would do anything just to get away from the family situation. Just wanted to be by myself, just isolate myself. And it was quite devastating for my family, very devastating. Got to the point where I ended up being divorced, and the situation became irreconcilable. So I lost that part of my life, unfortunately.
Thank you, delegates, and I hope you had a nice morning tea break. That was another of the videos that Tony mentioned earlier, and we'll be continuing screening those throughout the conference. It's now a pleasure to invite Professor David Forbes back. I shan't read out his life story again, much to his relief, I'm sure, but to present his session on what is needed to improve mental health outcomes for military and veteran personnel and first responders. So please welcome Professor David Forbes.
Thank you. Now, let me just check that I've... yes, it works. Lovely. So, look, thank you very much. Look, I'm here to talk about what's needed to improve mental health and outcomes for military and veteran personnel and first responders. And I'm going to try and cover the territory by covering through these topics. So, what do we know about prevalence? What are some of the commonalities between military and first responders, recognising that they are also different in many ways, but starting to think about what are some of the commonalities. What are some of the risk and protective factors that apply to high risk, high exposure organisations, and what does that mean for an overarching framework in terms of managing mental health and improving outcomes? And what are some of the key factors in terms of service improvement within defence and high risk organisations in terms of service systems? And then taking the opportunity to talk with you briefly about a new initiative that's coming through Phoenix Australia that's of relevance to many, if not most of you. So to kick that off, and of course much of this data will be known to many of you. So what do we know about prevalence of mental health problems in current and ex-serving veterans? Certainly the current seminal study is the study we mentioned earlier today from Sandy McFarlane and Miranda Van Hoof, looking at mental health prevalence in current serving members of Defence since 2010, and found a mental health caseness rate of about 20% across mental health disorders. Within the veteran community, this has been looked at through cohort-specific approaches. So Vietnam veterans through Brian O'Toole, Korean veterans through Malcolm Sim, and Graham Hawthorne ourselves looking at them through peacekeeper cohorts. And overall, we're talking about rates of about between 30 and 45, so higher rates in the ex-serving than in the serving. And both the Minister and Sandy McFarlane earlier today mentioned the Transition and Wellbeing Program. So this is now a body of research that's been done in collaboration with DVA and Defence through Sandy's unit, led beautifully by Miranda Van Hoof. And this is really looking at what's the prevalence of mental health problems in Defence members who have separated within the last 5 years. So this is going to give us our first snapshot of across the Defence Force, those who have separated from Defence within that critical 5-year period. What are the rates of mental health that we're looking at? And also, along with that is a kind of Pathways to Care report, which looks at who's engaging in care, what care are they engaging in, what are they receiving, and what are some of the factors that influence whether they do or don't seek care and the barriers to care. And that part we've been involved in. So, as the Minister mentioned, that's going to be presented over the course of the next month or two, and kind of looking forward to that coming out, and it's really a tremendous, tremendous study. In terms of emergency services, so many, if not most of you, will also be aware, so Beyond Blue are kind of sponsoring a national prevalence study in mental health across emergency services, and to the best of our knowledge have fairly high rates of promised participation across emergency services across the states. So that's going to be a really important bit of information in terms of the rates of mental health across the population. But until then, in terms of thinking about what rates are we aware of, really we're talking about specifically around PTSD. The data that we've got in relation to other mental health disorders from other organisations, there's lots of variability around measurement and design, so much variability that it's really hard to make consistent comments. So the best comes in relation to PTSD, and that's through a meta-analysis by Berger and colleagues, and for across emergency service personnel overall, rates of about 10%, ambulance 14, firefighters 7, police 4, and there's lots of obviously variability across studies with that, but that gives us a marker or indication. But again, looking forward to the Beyond Blue prevalence study over the course of the months ahead. In relation to the nature of mental health problems, and no surprises, most of the most common conditions are PTSD, depression, anxiety, other broader anxiety disorders, substance use disorders. And for those with mental health problems, a number of those present with complex combinations of these. So we often see the co-occurrence of PTSD, depression, anxiety, anger, aggression, substance use and suicidality in a subset of those with chronic and severe mental health problems. Often going with, well, while we often focus on the symptom picture, critically going along with the feelings of feeling overwhelmed, socially isolated and disconnected, difficulties engaging consistently in work, and unable to connect with their families. And as we all know, in the context of those with severe and complex mental health problems, it's often the families that bear the brunt of these experiences. So to extend out from that and just to talk a little bit about what are some of the commonalities that we see across military and emergency service organisations. Obviously a core theme is that many of them experience foreseeable and predictable risk of exposure to trauma. Many, not all, but many. So this is a core kind of unifying theme. This is a hazardous job. In the words of Professor Asano this morning, there's a level of toxic exposure that goes with some of the work that's done. And that's almost one way of thinking about it. But importantly, we kind of need to recognise, and frequently do, that these experiences and these potential exposures come in the context of operational stresses, shift work, fatigue, time-critical responses, issues around job control, issues around job autonomy, broader organisational stresses around leadership, management, supervision, the nature of peer and collegiate relationships and networks, and the adequacy of resources available to do the work, and environmental stresses around the climate and conditions of the area of operations itself. When we talk about what are the biggest predictors, I often hear in conversation issues of it's all about the exposures or it's all about the operational or organisational stresses, and I think critically we've got to recognise that we're often talking about combinations of the above. There's clearly a link between routine, operational and organisational stress and PTSD, mental health problems. And we'd expect that the high levels of stress may mean the person's less able to cope with some of the psychological demands of the potentially traumatic events. And there's also strong links between organisational support soon after a potentially traumatic event and PTSD, where organisational support has the strong potential to buffer the effects of PTSD or the impacts of the potentially traumatic events. One thing we're looking at currently in defence, we're engaged in a longitudinal resilience study that really is looking to examine what are the individual, the event, the situational and the broader system-based factors that influence resilience and the longitudinal trajectories in defence members over the course of their first 4 to 5 years in the services. So that's going to be, we're entering the final data analysis stage of what's been a fairly long-running study, and that's going to really help us better understand what are these trajectories and what are the broad array of factors that contribute to those trajectories and how do they affect in what order at what points in time. The other thing I think that it's important for us to be thinking about when we're talking about the kind of cumulative stress response, stress from all of the different directions and dimensions that we've mentioned so far. The other thing we need to remember is we're not talking about stress as a categorical response, either there's a stress response or there isn't. That when we see this, we're talking about something that's a dimension. So probably about 10, 15 years ago, it's perhaps a fraction less in vogue now than it was back then, but at that stage, everybody was doing what we call taximetric analyses. And taximetric analyses were looking to take data sets and say, is there a nature-bound cutoff? Is there an inherent qualitative shift in whatever this phenomenon or construct is that we're looking at in relation to how it's experienced? And the one thing we know from the taximetric studies that we did, that our colleagues in the US did, in relation to traumatic stress, for example, this was data drawn from traumatic stress in Australian Vietnam veterans across the community, a sample of about 600, was what we see is a clear dimensional structure. So we're not talking about folks who do and don't have these stress responses. We're talking about something that we expect to be something that is actually dimensional in its nature. So what are the risk factors within high-risk organisations beyond exposure? So as mentioned in all of the talks so far today, exposure is clearly a factor in terms of, to some degree, a dose effect of exposure. There's obviously variations in relation to something that has strong idiosyncratic meaning, where it really that event resonates for the person in a unique way. For example, the context of a child killed, same age as their child, will resonate in a way. It won't necessarily have a dose effect in the same way. So there will be these idiosyncratic responses to particular events. But clearly traumatic exposure is a high risk, which we'll talk about. But what are the other issues in the context of an organisational response that we need to be thinking about? So certainly role and function. So high contact loads, less experience, overwork, extended long working hours, isolation, lack of social support, poor role definition, lack of occupational support and supervision where it's appropriate, and personal histories around trauma or adversity, personal histories around anxiety, depression, and coping styles. So these are fairly familiar risk factors we see in higher risk organisations in relation to risks for development of mental health problems beyond exposure. And what are some of the protective factors that we see? And no surprise there, here we're often talking about the reverse of the risk factors. So the strong importance about establishing and maintaining strong emotional boundaries, clear and appropriate role definition. Critically, and I'll talk more about this soon, issue about occupational support, peer support groups, team building and an acceptance workplace culture around effective wellbeing. And critically also meaning making in relation to the work that's being done in terms of its outcomes and its intended outcomes and what that means for the belief system of the individual involved. And also again, what we said, flip side around personal, which is coping and personality style, internal locus of control, strong sense of self, strong sense of commitment, ongoing cognitive flexibility, and good affect regulation or emotional management, self-management. So the question then is, how do these things that we see in organisational contexts map onto what we know are the risk factors for PTSD across communities and across exposures, whether we're talking about disaster survivors, transport accident survivors, assault survivors, sexual assault survivors in the community. And when we think about what are the risks for PTSD in the non-organisational context, these are the factors that come up. So pre-incident factors, prior trauma, prior history of mental health problems, clearly incident-related factors, the nature, severity and duration of exposure, the degree to which the person felt their life was at risk or life was threatened, the horrors, the depth of the horrors they were exposed to, how long this went on for. And often going with that was senses of fear, of controllability at the time, sense of being able to control what was going on around you and the degree to which you could predict what was going on around you as well. And critically also post-incident factors, the issues about kind of support, lack of social support and other stressful life events. So putting all of those in a mix, what we've got is a couple of really strong meta-analyses that put all of these factors in the mix and said, how do these contribute and in what magnitude around the prevention of PTSD or around the risks for PTSD? Now these two meta-analyses are getting a fraction long in the tooth now, but they haven't been replicated. They were extremely strong. We probably do need to relook at this. But the really important part of this, I'm going to try yes, the pointer works, great. So a really important part of this is the strength of prediction around social support post-trauma and other life stresses. In these cases, overtaking trauma severity in childhood trauma. And that for us is fantastic news, particularly if we're talking about organisational context, because we can't control what life events the person came in with. We can't control a lot of those previous histories around mood the person might have experienced with, but we can't control the trauma. But what we can control is what happens afterwards. So it's really good news for us in working with organisations to say the things that are going to make the biggest differences to people's trajectories over time are going to be things that are within the control of the organisation. Things like social support, particularly within the organisational context, and also particularly in terms of ongoing stresses and the best that we can do to manage those. So for us, this is really good news around these being modifiable factors that are influencing the trajectories post-event. So the question is, what do we do with all of the above in terms of what does this mean for a mental health and wellbeing framework more broadly? And I'm aware that in speaking with you all today, I'm speaking to a diverse range of military emergency services organisations. Even within military, there's enormous variation within the military groups in terms of who's represented and the nature of the work they do. So recognising that there's a diversity here and that many of you we know are deeply involved in doing all of the things I'm about to talk about. There are a number who are considering a lot of these things. Other organisations are in the process of review. So we recognise that all organisations represented here are in different points. So what I'm going to do here is just talk about, if we're thinking about a framework, what do we need to think about? So if your organisation is doing all of those, please understand we recognise that, but it's a chance to be able to speak to that broader framework issue. So when we're thinking about a broader framework, we're thinking really about, at the outset, thinking about the important role about senior leadership. Ultimately, senior leadership, the role of senior leadership overarches all of this, and we'll drill down to each of these topics with slides. Sitting underneath senior leadership, the issue about a broad and comprehensive policy framework that speaks to all of the constituent elements. And underneath that is policies and strategies around primary prevention to maintain the mentally healthy workforce as best as possible, secondary prevention, which is what do we need to think about when we're trying to provide support for those who are starting to experience some problems, some adjustment issues, some symptoms of distress, if you like. And then tertiary prevention, what do we do for those who have developed full and frank mental health problems, and how do we address those issues? And as you can see from the diagram, underpinning all of this are the platforms around self-management, ultimately the individual taking responsibility for themselves and how they manage themselves, and also critically screening and step care, what an ongoing process of workforce monitoring and surveillance might look like, and how to be able to use that as a leverage point to allow people to engage in the level of care that they need. So when we're thinking about senior leadership, we're thinking about mental health awareness, taking a strong role around mental health awareness and advocacy, strong role around communication around mental health as a priority issue, and importantly that next dot point, which is actually being a role model themselves around self-awareness and reflection. So one is communicating a message, a really strong message. The other is being able to demonstrate that within themselves in one way, shape or form or another, that this is something that applies to them also and that is visible somehow or another in an appropriate way within the organisation or communicated somehow within the organisation. And overseeing the implementation of policy, we'll talk about the policy framework, but critical is around knowing not only that the policy framework is there, but taking an active role in ensuring the policy is implemented. And not uncommonly, we see gaps between having what can sometimes be a really well-articulated, erudite, comprehensive policies, but the gap between the policy and the facts on the ground can sometimes be larger than we'd like. So really important in terms of the role of senior leadership is being able to not only know these are the policies, we've got a comprehensive policy in place, but being able to see that through to know that it's actually being implemented correctly. Just having a look at the time, I should get on with it. Policy framework. What's that to include? So managing stress and trauma exposures, policy framework around exposure management, minimising unnecessary exposures, coming back to that issue about the potential inherent impact around trauma, which really across a workforce, we want people to be exposed only as they need to do their job. And so being constantly mindful about who's exposed to what. If you need to be exposed to do your job, that's fine. What does that involve? What are the parameters around that? And for those around who being cautious about what they need to be exposed to at what periods of time. And there's some interesting work that we're doing, interesting and emotionally very challenging work we're doing in relation to dealing with organisations who deal with child exploitation material, child pornography, and for those whose role it is to be able to make judgments around this material, take action in relation to this material, but the inherent problem of being exposed to the material as part of their work. So being really clear about what are you exposed to in what doses and how can you manage that to do your job but not overexpose yourself unnecessarily. Anti-bullying and conflict policies, enhancing a psychosocial safety climate. So what can you do to make it an environment whereby people feel like their well-being is catered for and the organisation is there to cater for their outcomes, their positive outcomes, and ensuring evidence-informed policies and processes in place for psychosocial support. Primary prevention, mental health awareness, self-management, peer support, all of these things familiar to you. Resilience training, and I think we'll acknowledge, and there's a number of presentations coming over the course of the next day and a half in relation to resilience. We acknowledge that this is an area that is still a work in progress, that we were clear about what the outcomes are for resilience. We're starting to clarify what mechanisms we're talking about, but the evidence and science around the interventions themselves is still growing. So that's it's an important area to be on top of. It's an important area to be immersed in as far as best practice allows, and know that we need to push the boundaries on being able to enhance our resilience training. Ensuring psychological first aid training is available and provided across the organisation, and broader workforce prevention policies. Critically, as we were saying before, active promotion around social cohesion and social connectedness, and having easily accessible mental health information, including resources. And often we'll hear that telling us, oh, there's information for the membership of the organisation available on the intranet, and you look on the intranet and you need a PhD to be able to find where the portal is. So one thing is having mental health information available, another one where an ordinary human being can find it. Secondary prevention, having mechanisms to encourage early intervention for people showing signs of distress, ensuring evidence-informed approaches are available, and providing good self-care information and tools, again, as we were saying before, as accessible as possible. And this issue around stigma and barriers to care keeps coming up. We'll be talking about it more in the Pathways to Care component of the Transition and Wellbeing study. But critically, we can do our best to change attitudes as best as we can, but critically, there are a whole series of behaviours and practical consequences that can occur in the context of help seeking within organisations, and critical is that we address those barriers to care, those things that actually have negative consequences for people putting up their hand. And we need to target those directly. Attitudes can change secondarily. We've got to change the actual clear behavioural manifested outcomes in the first instance. And importantly, guide to evidence-based treatments and workforce screening underpinning all of the above. And that can be informal across the organisation as they're trained up in psychological first aid or mental health first aid, or then also more formally in relation to more standardised workforce screening and surveillance approaches. And critically, in terms of a broader system issue, and there are a number of presentations over the course of the next few days that deal with each of these alone, so I encourage you to attend to those. Issues around integration and coordination of care. It's great to have all of the care points available, but often they're not necessarily as coordinated, as integrated as we want them to be. Critical about expertise in military and first responder culture. The cultural competence issue is critical. That the services that are provided by health service providers that just get the population that they're working with, that they understand them from a cultural perspective and from a clinical perspective, and that they are stable. And we also know, and critically, while we often think about this for military folks, critically also is the issue about transition out of forces for emergency services as well, and what that means in relation to identity and transition. And I know that Maddie from Gallipoli Foundation will be doing some presentation on that later on in this session as well, on the great work that she's doing. And we know a series of pilot initiatives, as the Minister mentioned, occurring in the context of managing suicide across the veteran community. As I say, across organisations, we know that everyone's in different places. A common thing to all, and I'll just spend a couple of minutes on this to finish up. Common list to all is, and across the field more broadly, is for those with severe and complex mental health problems and PTSD, and Sam McFarlane alluded to it earlier, the reality is we have a limitation in how effective the treatments are. One is we know there's a gap between routine care and best practice care, and that's a critical gap that we've got to address. If you have PTSD and you're seeking care, you've got about a 50% chance tops of getting the best treatments we've got. So there's already that gap. But secondarily is the issue is even if you're getting that, the reality is we've got about a third who do super well, a third who get large benefits but still remain symptomatic, and a third who experience little, if any, meaningful change. So really important is that we continue to improve these treatments, matching, adapting, tailoring, new interventions, augmenting, that we push the dial forward in being able to develop better treatments, more effective treatments across different dimensions, focusing on wellbeing and function. And just a brief mention to say that next Friday, the Minister for Veterans Affairs, Minister Tien, will be launching a centre that's kind of auspiced through us, called the Centenary of Anzac Centre, which is going to have two arms. One is a practitioner support secondary consultation service to provide support for those who are providing care, for those with complex mental health problems, across the veteran community initially and defence community, and also a treatment research collaboration to terms of working with yourselves across the field to work together to try and improve the treatments we've got, to move the dial forward on that together to improve outcomes. And critically, the two of these are going to work hand in hand. So as we are providing consultation, being out with you, working about how you're dealing with your complex clients, as we learn from that, that feeds into the research agenda for trialling new treatments. And as we learn from the research collaboration, we feed that out back into the community in terms of those who are doing the work. And collaboration is going to be integral to this. So making mention of our key partners, Richard Bryant, Sandy McFarlane, and Mel Hopwood, but key partners across all of your institutions, organisations, VVCS, PTSD treatment programs, ex-service organisations, the health professional organisations, treatment centres, and a whole series of international linkages, as well as with all of your respective organisations. And just to kind of note, the council that'll be overseeing this process will be these individuals, and we hope to see you at the launch next Friday. Thank you very much.